Dah, semua ada dah. Semua dah ada ke tak?
Dah, Doktor.
Dah ada.
Dah ada semua? So today we're going to go for introduction of respiratory system. So first of all, the introduction only. How to examine the respiratory system. The key to how to examine. So semua ada Okay. I'm going to the key respiratory examination. Okay. Respiratory examination is most important part or one of most important organ. You rasa organ yang paling penting sekali dalam badan organ apa? If you have choice, kata you all dapat choice, organ mana you all tak nak? You all rasa yang you rasa yang paling penting sekali, you nak keep first choice, kata or choose you. Organ mana you simpan dahulu?
Oh, heart lah, Doktor.
Heart. You nak simpan heart. Tapi kalau you tak ada brain, you ada makna ke hidup ni tanpa heart?
Betul juga, Doktor.
Tapi kalau ada brain saja, brain dihidup ke tanpa heart dengan jantung, heart dengan respiratory system? I think apa organ yang tak boleh di-replace in future? Heart dah boleh replace dah.
Brain.
Rasa brain tak boleh replace in future? Sure ke?
We can put it in that way for now.
Now lah, kita cakap future. Respiratory pun tak boleh tukar ke in future. Boleh lah kalau operation kita ada ganti, tapi kita perlu lung juga. Kita ada heart lung machine kan, which for temporary usage only. Okay, tak apa, introduction. Respiratory examination is one of the most important part examination in the patient. You start from units, do the ABGA score, ballot maturity assessment, and then, but one thing for sure, the most in children, unlike adult, many morbidity is due to respiratory problem. If you go to the hospital, to the clinics, majority of the patient came because of the respiratory problem. Adults a bit different. Adult, many of them came because mainly cardiac problem, hypertension, diabetes, and so on. But pediatrics, respiratory is the main consists of a lot of complaint, a lot of reason why the patient came to see doctors. Function of the respiratory system: breathing, chest exchange, defense function, metabolic function, deposited function, filtration function, endocrine function. That's the main. But the main function: breathing and gas exchange. The respiratory system started from oral nasal cavity, oral cavity. It went down to pharynx, larynx, epiglottis, then trachea. Then after that, it went down until the bronchial trees and lungs. Lung itself, the parenchyma of the lung, and also the vessels of the lung and the muscle. Don't forget the muscles. The muscles are part of the respiratory system. So the upper airway, you know how to differentiate from upper airway, lower airway. Upper airway is until the insertion of mandibular there. You see the insertion, the trachea inlet. 1/3 of the trachea is still considered as upper airway. So anything above that is upper airway. Anything lower than that is considered as lower airway. So the nose, pharynx, adenoid, tonsil, epiglottis, larynx, and trachea. 1/3 of trachea is upper airway. See, 2/3 of trachea, bronchi, bronchioles, alveoli, ducts, alveoli considered as a lower respiratory tract. Little bit of the surface marking. Anterior, remember the anterior, the right side have 3 lobes. The left side got 2 lobes. And the horizontal fissure roughly at the 4th intercostal bone. And then the middle fissure is from the 4th, from the 5th until to the 6th, it cross. And then the end of the lung margin at the 6 intercostals. Below that is a pleural space 7 where the pleural membrane end. Similarly on the left side, but more on the left side, remember the only oblique fissure. But the posterior side of the lung, the oblique fissure stay at the 4th, and then the posterior fissure, the cross, the end of the lung margin, the inferior part is cross from the 5th until 7th. So roughly the reason you need to know this, because when you touch your patient, when you auscultate your patient, you know which lobe do you examine. So summarize, you can see upper, mid, lower lobe, upper lobe, lower lobe. At posterior is upper lobe and lower lobe. At the posterior, mainly upper lobe and lower lobe, slightly small, usually smaller than this lower lobe. This is how the lungs like. Roughly tell you what the lobe do you examine. So when you examine, you start examining is always by observation. What do you observe? You observe the surrounding. Look at the nebulizer. Is there nebulizer, medication, special food, morbidity, hospital equipment, oxygen, fluid, center line. If it's for IV antibiotics, the child awake or alert. Are they running around? They seem to be generally ill or distressed. Who is them? Do you heard any audible cough, wheeze, breathing difficulties? This is the rough guideline for you to before you start do the proper examination. Even this is already considered as examination already. So as usual, the basic steps of clinical examination consist of history taking, inspection, palpation, percussion, auscultation. For the clinical examination, for the examination alone, we're talking about inspection, palpation, percussion, and auscultation. Your mind must have this sequence in your mind, standard. It has to be part of you. Inspection, palpation, percussion, auscultation. Always in this sequence. Sometimes in children, you cannot do it in the sequence because you have to take the opportunity whenever it's there. It doesn't matter. It doesn't matter because when you present in the sequence. Even if your examination doesn't follow the sequence because you look for the opportunity. Just remember, you have to have this in your mind. It has to be always part of you, the sequence of the examinations. Okay, as usual, wash your hand properly, introduce yourself to the family, good rapport, explain to do what you want to do, because you must realize that the child will observe your rapport with the parents. If your rapport is good with the parents, they can be cooperative. If your rapport is not good with the parents, they themselves will start to reject you. And then examination-wise, depends. In outpatient setting, perhaps you can unit at examination table. Preschool, probably you can examine if they want to examine at examining table is okay, better, but still usually at this time they like to reject. They have anxiety to the stranger. They don't like stranger. Perhaps sitting on the mother laps is better option. And then adolescent is examined like adult. And remember, wash your hand, clean your hand properly before you examine. Is part of practice of good hygiene. You don't want to transfer any of your bugs to the patient, especially patients who are immune compromised. And look, always observe the gender appearance. Gender appearance. Expose the patient properly. Expose the area needed, and it has to be properly exposed. And for the child under 2 years, maybe sometimes you can ask the parent to help you to expose, because if the parent opened up, undress the patient, the child, they are not that, because if you undress, the stranger undress, they start to fight you and start to cry, then you lose your chance to examine. Because undress the child for the parent, the child accept it as a routine. Remember, always the chest should be fully exposed and examined from the right side. Look at the posture, body position, body shape, skin colors, any unusual behavior, parent-child interaction, fat or skinny, rashes, scars. Ask if tenderness anywhere before start touching the patient. And look, then start with general examination. Don't forget. Always start with general examination. We're talking about respiratory. Ask you, can you examine the respiratory system? Start with examination. General. If people ask you, examine the abdomen, examine the chest, then you can start straightly go to the request. What if respiratory system mean general examination? So general examination involves examination of the arm, vital sign, pallor, look for clubbing, peripheral cyanosis, tremor. Because the arm, at the arm you look for pallor, clubbing, tremor, flapping tremor, especially the older one. Any wrist tenderness in adult, usually jugular venous pressure, axillary lymph nodes. But it's optional for the children, because this is the place they don't like you to examine. They start to be resistant. So pallor, position of lymph nodes, and clubbing, look for CO2 narcosis. And this one, clubbing. Remember, look for the clubbing. And then inspection of respiratory system consists of face inspection, nose inspection, throat inspection, neck, hand, and thorax inspection. Nose, look for nasal patency, septum, any nasal flaring, nose is snotty. That's for polyps, discharge, mucous membrane, and sinus tenderness. Throat, you can look for the color, fissure, dryness, tongue, teeth, gum, especially hypertrophy of the tongue, of the gum. Throats, look at the throats. That is chart. In this case, you can see the throat, the tonsil is enlarged and inflamed. Tonsilli inflames. And then the sign of inflammation of the tonsil. Inspection. Okay, when you look, after you examine finish the face, the nasal and the mouth, then you go for the chest and the neck. But you observe first. You look at during observation, you see the respiratory rate, rhythm, depth, quality. And then you try to listen. Any noisy grunting or snoring, listen for that. Any noisy breathing, grunting, or snoring. And then you have to understand a few things. First, First, you have to understand the inspiration, expiration. The inspiration are shorter than expiration, and the rate are difference between according to the age. This is roughly the rate according to the age. You have to understand that the rate in younger children is faster than the older children. And then when you observe, also look at is there any abdominal breathing pattern? Because you look, is the tachypnea, the type of disorder of breathing pattern, like respiratory rate, depth of the breathing, What you do is tachypnea, bradypnea, dyspnea, apnea. Or for the depth of the breathing, hyperpnea, hypoventilation, hyperventilation. Okay, I'm telling you things that you should know. You should know as when you do the practice. But the main thing you will notice is tachypnea. It's okay. The rest you will learn when you go deeper and deeper in the medical field. The bradypnea, dyspnea, apnea, all those things. But the main thing is a tachypnea, increase in respiratory rate. And then if you can look, the thing is hypoventilation, hyperventilation. Is something if you can develop this observation finding, then it means that you are good. Look for the accessory muscle usage and intercostal respiration. Is there intercostal recession? Look. I remember that pattern of respiratory rate, the pattern of respiration in children is not that similar to adult. Less than 6 years, they can still use abdominal pattern. I mean that you see the movement more in the abdomen rather than in the chest. But more than 6 years, they mainly use the chest movement. Because in adult, if you saw the patient using abdominal respiration, you know something is not right. But in children less than 6 years, they tend to have abdominal respiration. So what the pathological respiration? Is there any paradoxical respiration? I mean that the chest move during inspiration, the chest, the abdomen expand during inspiration, and the chest fall during inspiration. Dia terbalik, rather than usually the chest expand during inspiration and abdomen went down during the inspiration. But dia terbalik, paradoxical movement. The other one, small breathings, is a hyperventilation. Due to gasping and labor respiration, usually due to respiratory acidosis. The other one is giant stop respiration, is due to because of the brainstem injury, which is alternating breathing in high frequency, low frequency. You mean breathing, then slow, the giant stop breathing. Tell you that brainstem injury. If you in adult, you saw many of this in the infarct case, stroke case, when you involve the brainstem. So you then after you observe generally of the chest movement, then you see the anterior chest wall. Then, okay, second, what is the position to examine the children? Okay, if you can ask the children to lay down at 30 degrees to 30 degrees, 45 degrees, 30 degrees, then it's good. If you can ask children to do that, that is the right position for respiratory examination. But in children, the most important is to make the child comfortable. It's not you to make your life easier. It's to make the child comfortable, because how much the child cooperative depend on how much you make them comfortable. So if the child rather want to lay down supine rather than sit up 30 degrees, let it be. Let it be, because we want them to be comfortable. What they want, it doesn't matter. Though in adult, yes, the standard practice 30 to 45 degrees. So remember, inspect the shape of the chest, especially the anteroposterior talus diameter. Inspect the symmetry of the chest, any bulging, and look for the shoulder. Is there any shoulder drop? And then inspect the position of the trachea. So on the wall of the chest and the skin, look for swelling, scar, sinuses, skin eruption, engorged vein. Look for the horizontal sulcus, which is two symmetrical sulci horizontal at the lower margin of the anterior thorax, And then if you can look at the thickening of costochondral junction, especially because it can be a recurrent rosary in the vitamin D deficiency. And inspect for any retraction of low of intercostal space, and then look into the apical and epigastric pulsation. So at the back also look at the deformity, any deformity of the chest at the back, and look for curvature of the spine, either kyphosis or scoliosis, and look for any scar. So basically is a chest shape. This is a fernal chest. This is a pigeon-shaped chest, pectus carinatum. This is a barrel chest. There is barrel chest. This one is mainly pectus carinatum, but this one got depression due to Harrison suckers whatsoever. But this one, because barrel just due to because of the, especially in adult with COPD, barrel chest. The pectus carinatum and pectus excavatum. This one is just fernal chest, pigeon chest, barrel chest, and then there is a. So this one is one of the. This one can you see pectus carinatum with the depression. So this without depression, but then we describe it as barrel chest, pigeon chest, and fernal chest. And this one, if there any up, the shape of chest is bulging up, pectus carinatum. If the sternum bulging, sternum went down internally, pectus excavatum. So then after that, you look at the neck, look for tracheal shift. The tracheal is go to which side? Left side, because the tracheal normally go to slightly on the which side? Left or right? Slightly on the right side, slightly only. And then because sometimes because a mediastinum shift result in obvious tracheal shift. And then how to examine is to put, usually the big children you put 3-finger technique, small children just 2-finger technique. Difficult to, we can talk about technique later. Look for tracheata and examine the lymph nodes. Then after that you palpate the chest wall. Okay, before the palpation, always remember that you divide in your mind the chest of the wall of the patient have 3 zones: upper, mid, or lower zone. You have to imagine it in your mind. So the first two rib will be the upper, 3 to 4 is middle, 4 to 6 will be lower. Always keep them there, because because at the 6, below than 6, usually you are beyond the lower margin of the lung, because lower margin of the lung anteriorly at the 6 in rib. So you imagine that upper, mid, or lower zone before you touch, because your examination technique depend on the upper, mid, and lower zone. So when you do palpation, because you want to palpate palpation, but you do palpation not only chest expansion, but also you want to look for bronchi, pleural rectum tenderness, and then you examine your palpation, the chest expansion using the upper zone, mid zone, and lower zone. So when you see the chest expansion, you want to see the asymmetry and the extent of the expansion. And then there is do chest expansion. The anchor must be persistent here, and then it's your finger, and ask the patient to take the deep breath. Okay, if the patient can cooperate, nice. If the patient cannot cooperate, don't push so hard of it. Don't be so frustrated. In children, the younger they are, the more difficult. And sometimes the chest, difficult to do the chest expansion, because let's say in the baby, your hand is much bigger than your palm is bigger than the baby chest. So don't be so frustrated if you cannot do it in the younger children. So then you palpate the heart location, the apex beat character, because it tells you the mediastinum displaced or not. And then assess for costal vertebral tenderness, And then if you can do vocal parameters, it's nice. If you cannot do in children, it's especially young children, then don't be so much frustrated. Usually we ask to put at the inferior internal part of the small finger palm, and you put at every space of the intercostal space, and you ask the patient to say 9, 9, 9, 9, and vocal parameters, because the increase can show you probably there's something there. The decrease also can show you probably is something there. Then percussion techniques. Okay, percussion is very important. The technique has to be correct. This is very important. If you cannot do proper percussion techniques, most likely you cannot get the finding. The technique is that the movement is only at the here only, until at the wrist. The wrist only here. Your forearm didn't move. And you must hit 90 degrees, 90 degrees and one finger. Some people use 2 fingers, some people use 3 fingers. In the exam, some people use 2 fingers. I don't think it's nice to do that. You use a 1 finger technique. You may say that your finger is small and so on, but I tell you, if you practice it properly, how small your finger, you can do it. You have to be 1 finger hit 90 degrees. Some people practice 2 fingers during the exam. I told them, you don't need. You can, if you practice properly, 1 finger is enough. Mean that you have to practice. You have to percuss everything. You percuss your table, you percuss your book, you percuss your knee. You see the difference in the sound reflection. Each material can give you different sound reflection, and your ears have to learn that. So the percussion is, you have, I mean, when you percuss, usually you remember a few things. You have to know what is resonant, what is dullness, and what is the liver dullness, cardiac dullness, tympanic, and also you have to know the hyper resonance. You have to know. Yes. Ada teaching.
Ada satu kes tonsillitis. Ada nuclear case. Obat itu masuk baby boy. Tonsillitis tengok ada infected granuloma.
Infected, ambil lah. Kata nak start IV antibiotik. IV swab everything, ambil for IV antibiotik.
Cuma yang bahagian ini memang universiti saja Datuk dengan
tak payah.
Ya, confirm. Dr. Aziannya input saya letak dekat bawah X-ray tadi.
Okey. Diantara. Diantara.
Diantara. Yang smart boy depan.
Dia dah komen apa?
Dia komen, dia betulkan banyak saat saya gabungkan kebetulan Datuk dengan kebetulan dia.
Dia komen apa? Language kan?
Language. Dengan dia, tapi dia
language. Okay. So when you do the percussion, the second thing when you do the percussion, there are you have to differentiate between the left and right of the chest, and second thing you have to percuss the zone, upper zone, mid zone, lower zone, and then you have to percuss from up to down to every. So what we do usually we percuss every intercostal space. We go from the right side and the left side. So when you go for the left side, you go down until you feel where the liver dullness is, and you noted the liver dullness, where is it? On the right side, left side, you percuss every intercostal space. When you until you feel then you recognize the cardiac dullness, which is not as dull as the liver. Then you feel the tympanic. That is the first you done. Then after that, you percuss left and right. You percuss left and right is upper zone, mid zone, lower zone. Just that's all you do. Compare left and right. By right, there's not much difference. Then how you percuss. The posterior, the mid axillary side, the lateral side usually we don't do in children because the wall is unless because the children punya chest is not wide enough, unless it's in adolescent or big children. At the back we percuss. At the back when we percuss, similar technique. You percuss downwards first, and you compare to the upper, mid, and lower zone. But in children, we forget the scapula because difficult to get the interscapular space. So just percuss directly down. Adolescent, yes, you can decide to do interscapular space if you can get the interscapular space. That's how you percuss. But the important is that to understand the finding. So you have to understand that the finding, resonant, liver dullness, and then the tympanics, and also you have to know the, where is it? What is hyperresonant, upper dullness, upper stony dullness. So the dullness you can hurt in pneumonia, hemothorax, water in the lung, in the thorax, pulmonary edema, if there is any tumor. Hyperresonant, Bensbach ni hyperresonant. If you can this emphysema, pneumothorax, asthma sometimes can be hyperresonance, asthma, and then if there is any cavity in the lung, abscess if there is cavity, it depends. If the abscess a lot of fluid, then you be dull. But the abscess mainly a lot of air, then it can be hyperresonance. So you remember this normal when you percuss. Remember that this what the thing that you percuss. There is a lung which is resonant. Resonance is normal. It's like cardiac dullness, liver dullness, and tympanics will be here where there is a stomach. So at the back mainly is the resonance. So resonance, hyperresonant, tympanic, dull, and flat. Remember. You have to practice. I don't know. You practice your lung first. You know it's resonant. If you practice, then you found any patient who have COPD patient or patient with emphysema, then hyperresonant. You have to practice that. Any patient with dull, solid, you can percuss with the dull. Then if it's water like pleural effusion, you be stony dullness. Stony that you percuss like a stone, very dull. So auscultation. Cool. In auscultation, the technique is by right. Patient has to relax, breathing with mouth open. Relax. That's how by right. But in children, well, if they can obey your instruction, then it's good. If you cannot obey your instruction, then what to do? You get whatever you want to get. Even on crying, also sometimes you try to your best to get any information when the child cry. So you listen on. You have to listen. So when you auscultate, you still imagine upper, mid, and lower zone. Upper, mid, and lower zone. You still have to imagine that upper, mid, and lower. You have to imagine that. And then you auscultate left, right, left, right, left, right. Okay, at least you have to listen to breathing. To tell you to at least 2 breathing, then you can satisfactorily you can make your decision. Inspiratory, expiratory, inspiratory, inspiratory, the expiratory. The first one you notice the finding. The second one to confirm your finding. If you're not happy, then you can listen more than that. Doesn't matter. And then you ask the patient to take breathing, so you can hear you should hear the air in and out, in and out. Okay, first you listen for the breath sound, then you listen to any additional sound. Remember that. And then you to assess compare the opposite side. You listen for the length of inspiratory and expiratory. You listen any pause between the inspiratory, the expiratory, and quality or pitch of the sound. And then you compare the sound between the upper and lower chest, and compare the intensity of the sound also, and listen for any additional sound. So basically they are vesicular breath sound, or bronchovascular breath sound. And then there are bronchial breath sound also, you have to realize that. And then you have to know the absent or diminished breath sound, air entry. Because anything, fluid, air, solid mass can affect the conduction of the breath sound. And then because the diminished breath sound can alert the doctors the area of the problems. And then basically it's something like this. Bronchial breath sound, when you listen at the region of trachea here, there is bronchial vascular breath sound, and this a vascular breath sound, roughly posterior chest, something like that. So same. So you see the bronchial breath sound, there's not a gap. Air doesn't move, gap. It just tell you the air movement in the large airway. The trachea, large airway. Bronchiovascular breath sound, they are movement in, because the bronchiovascular, so you auscultate, you listen both the sound from the alveolar and the bronchiole. So you listen, there is a, because in bronchial breath sound, the expiratory is longer than inspiratory. Then you see the bronchiovascular breath sound, inspiratory, expiratory, nearly the same. Same. So, but the vascular breath sound, with the periphery here, when you listen the sound mainly from the aeroli, then you listen the inspiratory is longer than expiratory and is shorter. And then is a sound is more, the intensity is less. Just like that, but inspiratory sound, intensity is less, but there's no gap. So very important to recognize these three sound. And then the other thing you can try is vocal resonance. If the patient is cooperative, if patient not cooperative, is okay. Patient cooperative, if the child is big child, that you can do. And then what you want to listen is that the three types usually. Whispery petroloquy, which you listen as if when you ask the child to say 999, the sound is seem to be just at your ears. Or bronchocony is just the sound is high, but at the increase, usually is increase in consolidation. Where there is, you listen, it is at the chest, but it increase. But this one very nice. I heard a few. You made the sound as if in the ears, and you found it easily in the adult who has bronchopneumonia. And then the bit about breathing pattern. We told that before. So what abnormal finding you want to look at? This is knowledge now. A few knowledge that you have to keep about in you. One is breathing pattern. We have to go. We have done the examination and breathing pattern. Okay. The other thing if you want to complete your examination, is you also examine the abdomen to look the. So we don't see. We go okay. We go this one first. Okay. What the abdominal thing you want to look at? One is recession. Look into the recession. Second, the sound, the stridor. Third is the wheeze. You tahu wheeze and stridor, difference, very important. Wheeze. The stridor mainly at inspiratory, it tell you the large airway obstruction. Wheeze to tell you that the small airway obstruction. Grunting. Grunting is mean that the child try to open the airway by increasing the pressure. Grunting. Using the accessory muscle, result in the recession. You have to recognize that. Gasping is where child is really bad. Then crepitation. Crepitation and crepitation and bronchi. Crepitation. Crepitation is in US dia pakai rails or crackles, but in Malaysia kita pakai crepitation. So the capitation you have to look, is it fine capitation or coarse capitation? Remember, and is it an inspiratory or doing the expiratory? Ronchi, ronchi, just remember ronchi only, no need no civilian or sonorous. Ronchi, the ronchi you have to know is that is it inspiratory or expiratory ronchi? So you have to look, and then the if you want to anything extra, would like to explain, there is the breathing patterns, takipnya, bradynia, apnea, hyperpnea, chain stop, and small breathing. The rest tak payah tahu lah. Yeah. And then after that, you say you want to complete the examination, but examine the abdomen. Don't forget to examine the abdomen to look for the what? Anybody? To look for the liver. Is the liver being pushed down or not? Push down or not? Remember that the liver in children is palpable until the age of 2 years. Until of 2 years, they're still palpable. But then, as if they are very significantly, the lung is very significantly the barrel shape or aspect hyperinflated, then they can push the liver down, and you can see the liver, you can feel the liver being pushed down. It tells you something that the lung is hyperinflated. So very important, after you have examined the child, you have the you get the finding, you must be able to interpret the finding. You must be able to interpret the finding. So what is it? Let's say you have to, let's say in broncho pneumonia, they can reduce movement at the affected site. They can have a rapid breathing, tachypnea, percussion is dull, auscultation reduce air entry, and there is a crepitation. If asthma, you can see that child or inspection, hyperinflated chest, using accessory muscle, Harrison sulcus is prolonged, percussion is a hyperresonant, the lung is auscultate, a lot of bronchi. So there is some findings. So basically, interpretation of finding that if you got pleural effusions, reduce vocal fermenters, reduce chest expansion, stony dullness of percussion, reduce air entry, no added, there's no sound at all, no capitation or whatsoever, reduce vocal resonance. Consolidation, increase tactile vocal fermenters, reduce expansion, dull on percussion. So the difference that is stony dullness, there is dull, there's bronchial breathing, because of the alveoli is collapsed. What you listen is the airway breathing only. Cause capitations, increase vocal resonance. Sometimes you can hear the vocal resonance at the ears, whispering, pectoraloque. Especially you can demonstrate in adult. Pneumothorax, derivated trachea, trachea is derivated out of the away, trachea derivated away. I mean, if the pneumothorax on the right side, the trachea will directed to the left side. Reduce vocal fermenters, hyperresonant at the place, reduce air entry, reduce vocal resonance. If lung collapse, divide trachea is directed to the site of collapse, reduce vocal fermenters, dull on percussion, reduce air entry and capitation. So you have all this finding, then you can decide. When you examine the child, you get the finding, you have to decide what's the abnormality. When you decide the abnormality, you have to know is it effusion, consolidation, air, or collapse. And then after that, you make your diagnosis. You make your diagnosis, and then after you make your diagnosis, then you make the diagnosis. This is the diagnosis, and this is the finding, interpretation. Okay, any question?
Doktor, kalau in long case, kalau patient is not cooperative, how do we present the findings?
No, if the patient not cooperative, sometimes you examine. Okay, there are two. One is you practice as a doctor. I think that's what you have to think first. You are practicing, training and practicing as a doctor to get your skill. That is the most important. Okay, that one you try to practice. You have to have a good technique in order to have the good finding. So your technique, everything correct. You try to practice examination as in the sequence, because the sequence, and then you present also your thought process also in the sequence, and then your presentation also in sequence. That's the first thing. But during the exam, usually we will get you the child who are cooperative. That's the first thing. Understand or not? Because the child not cooperative, not only the person who taking the examination in trouble, the patient who took the exam, the student also have difficulty. So usually we will get you children who are cooperative. If the children not cooperative, you examine in the way that you can do. But when you present in sequence. You know the sequence? You present in sequence, started from the observation, from inspection, and then from the palpation, auscultation, and the rest. You go. So you go according to the sequence. Okay. That's how you do it. So forget about the exam at the moment. No need to worry about the exam, because exam only to test is if you are qualified to be a doctor or not. The most important for you is to get your technique correct so that you become a doctor, a good doctor. Anything else? Ada apa lagi?
Doktor, for infant pun ikut cara yang sama juga. For infant, do we examine the same way?
We try to examine the same way, but we adapt. You see, one thing about pediatric, you must be smart. You must be smart and flexible. That is one thing about being a pediatrician. You cannot have everything follow in order as what the order are like. If you cannot get the optimize your finding, and if it's useless, and then if it causes more the patient more uncomfortable. So you have to adapt. You have to see what you can do, what you can't do. Okay. All come with practice. You see, there are 1.5 kilo, there are 3 kilo, there are 6 kilo, there are 10 kilo, there are 12 kilo, so there are 20 kilo. So there are different age of the spectrum or the age in pediatric are too large to have a standard practice how to examine. When you see your patient, you already decide how are you going to proceed. There are baby who are 10 kilo, infant, there are baby who 5 kilo. So how are you going to proceed? There are baby who saw you, start seeing you crying only. There are baby who still playful when they see you. So you have to adapt. Any questions? Anything else? Okay, finish, yeah? Okay. Ada apa lagi tak?
Doctor, before we end, just want to confirm about next week session.
Nanti I answer you on Saturday, Friday.
Oh.
Because first of all, I don't know where the timetable is. The second thing is that I have to go through with my timetable and try to reconcile it. Because the keep changing of the timetable difficult for us because we also have things to do. Okay.
Okay, doctor.
So you all to be flexible, I also have to be flexible. Once this thing are over, perhaps we can have more better way of organizing things. At the moment, everything is ad hoc. You have to realize that we also are doctors. We also have things to do. And then sometimes we also have meeting to go. And there are things that sometimes we have to prioritize also. So we have to see. Sometimes the thing come out because difficult to plan because the timetable keep change. Usually, what happens is that we when the timetable was given at the before the started of the block class, we already key in our diary, and then we adjust few things already. Sometimes we follow, sometimes we adjust the different day and so on. But when things keep changing every 2 weeks or every 1 month, then it's going to be difficult for us to adjust things. So I decided to do weekly basis, easier. In case something come out, then no more. Because if not, let's say my timetable is crowded with sometimes got 3 learning per week. Because the old learning coming and a new learning coming, so I don't know which one to potong. Because which is the real timetable, I'm not sure. So I go step by step. I think it's going to be like this for time being until we can sort out this COVID things. So you all have to be flexible. Very important. Do you use your time properly? Because I think you have a lot of time. Last time you duduk kat sini pun, you duduk kat sini, you boleh, kalau you tak belajar pun, you keluar makan, ni semua, huha dengan kawan, everything semua. Now you have, you duduk dalam rumah, makan minum, jadi gemuk. That's all. You have to use your time lah. Belajar, baca banyak, and those things. So we try to find a way to adapt. We also, everybody are adapting. I'm not sure when I'm not sure when the COVID-19 sort out, how much we're going to adopt this kind of teaching. Because e-teaching, one thing good, is very flexible to us. Because you see, if I have to drive to come back, it take me half an hour already. Spend half an hour just to find the parking and so on. This thing really save our time, my time. But I don't know how much it help in terms of. There are things that we have to do face to face. There are things we have to do. We can use e-learning, because I think slowly we are start mastering how to teach you all by e-learning. And I think the e-learning will be part of us, but we have not yet decided how much it's going to be. Because e-learning I found out it saves everybody time. I can teach here inside. I can do other things at the same time. So it saves our time. And that e-learning I can do if I'm busy. I can do it at home. Teach you, duduk kat rumah, I teach you all. So remember last session I teach 3 clinical in 1 day, because very difficult, so difficult to find a time during the day, do the weekday, so I do a weekend. But then there are negative aspect of it, because the how much opportunity you're going to get, the learning is really real learning is one thing. But the good thing I found out that I can see your face, muka you all direct. Cuma I want the zoom, kalau boleh 7 masuk sekali muka ni. Sekarang 3-4 saja boleh masuk. So I can see your face, I can recognize your face. Tak ada mask, tak ada apa, I can recognize your face. I know you're sleeping or not. Kalau tidak, duduk kat belakang, I nak tahu you're sleeping in front of me. Here, you're tahu you're supposed sleeping. So they are good and bad. They're good and bad. So the good things, probably somewhere end of the year, we're going to sit down and look into how to optimize everything. Okay.
Okay, Doctor.
Okay. Keluar pula.